Good?
Can you turn it on in the control room so if Lindsay comes, she can sit in there or no?
I can turn the camera. Yeah, I can turn that on.
All right, go ahead whenever you're ready.
All right.
I'll close the door.
Hello, my name is Dr. Brian Maloney. I'm a psychiatrist at the University of Toledo, and I am here today to talk to you about dementia and the approach to treatment that we take here at the University of Toledo to treating our loved ones with dementia. This is largely meant to be an educational video for family members and loved ones to explain the approach that your loved one will, to explain the approach to care that your loved one will receive when they receive care at the University of Toledo Senior Behavioral Health Unit. When we're talking about dementia, we are really talking about cognitive decline or brain function declining over time. If we were to put this on a chart, and we have brain function on the y-axis, and time on the x-axis, with the very top here being 100% brain function. I'm first going to talk with you about some examples of normal brain function so that you have a context to understand what's happening in the pathological process of dementia. On this spectrum of brain function, I want you to imagine that there's a level of brain function represented by this dotted line here that I will call the symptomatic threshold. The concept is that as long as we're above this symptomatic threshold, we're able to function normally. If we happen to drop below this symptomatic threshold, we'll begin to have problems. In the context of normal aging, where you have brain function that may decline ever so slightly, and this line is meant to look like it's declining just ever so slightly over time, you'll see that we have lots of cushion here above the symptomatic threshold. If I'm represented on this line here and I get sick here, I may have an impairment in my brain function as I'm sick, say fighting a common cold or a UTI or some sort of trauma to the body, and I will drop down in my brain function. But as you see, as I drop down, I'm really only kind of using up reserve capacity or the cushion of brain function that I have, and I never really come close to this symptomatic threshold. So even though I'm sick and not functioning at 100%, I'm still able to go to work, pay my bills, drive, cook, clean, do those things of activities of daily living and functioning without any errors. I may be a little bit slower in my cognitive processing speed, decision-making, calculations, but I'm still able to do those things and function well. And then as I heal, I come back up to my normal 100% brain function. Another example that I often use is the example of alcohol consumption. Most people have either seen or participated and experienced personally what alcohol can do. So if you're here and you have 1 drink, 2 drinks, 3 drinks, everybody's a little bit different. But the idea is that you can drink yourself into a dysfunctional state. If you consume enough alcohol over time, in a short enough period of time, you can cross over this symptomatic threshold. People may slur their speech, they may have incoordination, impaired reaction time, they may say or do things they wouldn't normally say or do. They may be more impulsive, more emotional ups and downs. And then, of course, as the body clears that alcohol, they'll come back up to their normal functioning. So those are some examples of normal things that we may encounter on a day-to-day basis and how they impact our brain function. I'm going to clear this off, and now we're going to talk, add this line back in for the illness. Now we're going to talk about dementia. Now every dementia has a different course and it may look slightly different, but the general concept here is that with a dementia, what you have is a neurodegenerative process that leads to a decline in brain function over time. So now what you can see here is early on in the dementia process, the cushion that you have above this symptomatic threshold gets smaller and smaller. So we may have a period of even years where we're still functioning okay, but we're in this dementia process where this cognitive decline is occurring. And now what you'll see is when somebody comes in to the hospital for a problem related to dementia, whether it be an emotional disturbance or a behavioral disturbance, what we're trying to do is we go through a 3-step process. We're trying in all 3 of these steps to optimize their functionality, their cognitive functionality, their ability to process their environment, to make sense of the world around them, and to help with any emotional distress that they have. The concept here is that in a dementia process, number 1, you may have an illness. And if I have the same kind of illness that I had when I was functioning at 100% or close to, now I get that same illness, a UTI, a cold, some sort of trauma to the body, and I have that same type of drop in brain function. And now you see that that drop is enough to tip me over the edge, so to speak. So this is a scenario where a medical process can sort of throw our loved ones who are struggling with dementia into essentially a delirium on top of the dementia. So we may have impulsive behaviors, agitation, hallucinations, auditory or visual hallucinations, irritability, disturbed sleep, impaired worsening memory or cognitive functioning, confusion, not able to do those things on a day-to-day basis to take care of ourselves. So the first step that we do when somebody comes in to treat a dementia patient who finds themselves in a behavioral disturbance or emotional disturbance is we're looking for any underlying medical problem that may be causing this dip in brain function. We're going to try to identify that problem and then we're going to treat it. So if they have a UTI, we may give them some antibiotics to help treat that UTI, all the while keeping them safe in our inpatient unit. The other, cut that there, and we can restart here. The other process that we look at when somebody comes into the hospital is we review all of their medications. Polypharmacy in elderly is very, very common and often causes problems. So just like our alcohol example from before, oftentimes we have a whole list of medications that sometimes those medications, while they're meant to help treat other medical conditions, may actually be contributing to the decline in brain function, just like alcohol does. And so one of the other things that we do as part of step 1 is we're looking for any medication, any offending medication that may be contributing to cognitive difficulties with our loved one, and we're going to try and clean those up as best we can, taking into context their whole medical picture. That's step 1. Step 2 of this process, again, really about trying to optimize their brain function, help them be as awake, alert, aware as they possibly can in order to process their surroundings. We turn to the FDA-approved medications for treatment of dementia processes. There's really 2 classes. The first class is what we call acetylcholinesterase inhibitors. Acetylcholinesterase inhibitors, imagine a volume knob on a radio. And what they're doing is they're turning the volume up on a neurotransmitter in our brain called acetylcholine. Acetylcholine is responsible for memory formation, memory retrieval, alertness, and awareness. When we wake up in the morning, it's a surge of acetylcholine that helps us to come into consciousness and make us aware, helps me to know that I am Brian Maloney, that I had to go to work today, that today was Monday, and helps you kind of be aware of what's going on. Decreases or drops in acetylcholine are one of the problems that can lead to memory impairment and cognitive difficulties in dementia patients. So by turning the volume up on acetylcholine, we can kind of help that process. The second medication or class of medication that we look at is called an NMDA receptor antagonist. There's only one medication in this class, and it's called Namenda or memantine. The combination of these 2 medications, what we're trying to do is something like this. We're trying to improve that functioning and impact that level of functioning to make it a little bit higher than it otherwise would be. As you can see here, we don't necessarily get a sustained improvement in function over time. This individual is still going to be declining, but if you look at where they were and look at the gap, you'll see that that gap can sort of widen in the level of functioning. So even though they're declining, they're better off on these medications than they would be without the medication based on their level of functioning. These are studies that were done over 5 and 10 years that sort of bore this pattern out, and you can see that we're trying to help our loved one function at a higher level than they otherwise would be. That's step 2. Step 3, I'm going to clear the board here, and we're going to talk about this picture in a more comprehensive way. Thus far, this is a pretty simplistic view of the brain. We're going to recreate our symptomatic threshold here. And now I want you to try and imagine this brain closer to what it really is a complex circuit board with lots of different circuits operating in this brain. And if you imagine that the neurotransmitters, the chemicals, the messengers that are affecting each of those different circuits are like little volume knobs on our radio. Now we're looking at adjusting the volume knob on maybe many different circuits. Instead of one line drawn here representing the cognitive decline, you can imagine I could draw 20 lines. I'm only going to draw maybe 3 or 4 here. So the concept here is that the entire brain is under assault, and all of these different circuits in the brain are declining, but they're not necessarily declining at the exact same rate. So what you may see is that as we progress in dementia over time, more and more of these circuits, if you will, these areas of domain, may cross below this functional threshold as time continues. Once we've done everything that we can to maximize their cognitive abilities through cleaning up their medications, through treating any medical problems that they may be having, and trying to optimize their cognitive functioning through the FDA-approved medications, we turn our attention to problematic circuits that we may identify. So for example, it is not uncommon for a loved one with dementia and behavioral disturbances to have psychosis, auditory or visual hallucinations coming into their mind, hearing things or seeing things that other people may not see or hear. We may have anxiety as a circuit that's declining. We may have depression. We could have sleep disturbances. We could have impulsivity. We could have changes in personality. We could have decreased or disturbed appetite. We can have motor function declines. On and on the list goes as to the different sorts of problems that we can have as different circuits decline over time. So after we've done what we can to maximize their cognitive functioning and try and minimize any problems they're having due to the brain dysfunction, we then turn our attention to individual circuits where we may be having a problem. So here, if I have my loved one here and they've fallen below on this circuit, and it happens to be a circuit that we think we can address with some medication, such as the presence of hallucinations that are distressing, we may try to adjust the volume on that circuit by using a dose of medication. And the concept here is that we're just trying to tweak that volume to get that circuit back above that symptomatic threshold. I'll give you a few examples so that we understand the dose of medications that we're typically using in this scenario are not very high doses. Risperidol is an example of an antipsychotic medication that can be used, for example, in schizophrenia. I may have an adult patient on anywhere from 6 to 8 milligrams at the high end of the range in terms of what we use to control those symptoms. Oftentimes in dementia patients, we start with 0.25 milligrams and sort of titrate that dose up until we get that circuit back above that functional threshold. Very, very rare that we exceed 2 milligrams in a dementia patient that we're trying to treat. So the concept here is that we may be tweaking this circuit, but we're not cranking the volume up on that circuit. We may not need to use the dose of medications that we would use in an adult. I'll give you one more example. There's a medication called gabapentin or Neurontin. Gabapentin or Neurontin is FDA approved for neuropathy. An adult may be on a dose something like 1,600 milligrams 3 times a day for treatment of the neuropathy. Gabapentin in dementia patients is a wonderful medication that may be used as an anxiolytic, will help with anxiety, can help with pain, may be a secondary benefit, and can help just overall with restlessness as a mood stabilizer. We may use 100 milligrams 3 times a day as compared to 1,600 milligrams 3 times a day in an adult with neuropathy. And again, the concept is we've identified a problematic circuit that is below that functional threshold, and we're going to tweak that volume on that circuit just to get it above that symptomatic threshold. So that's the overall approach to treatment of dementia with behavioral disturbances and emotional disturbances. I hope you found this educational, and please feel free to ask your treating provider any additional questions that may arise from this discussion. Thank you so much. Good?
Yeah,
All right.
perfect. You're all set. I'll take
All
your
right.
mic and you're out of here.
Perfect.
See? Super easy. Plus, I think it's easier when it's easier.
Yeah. Good enough for everyone.
Thank you so much.
No problem. Thank you.
And I'll get that to Lindsay.
All right. Take care.
Thanks. Have a good day.
Thanks. You too.